Well, welcome everybody. We'll go ahead and get started so that we can stay on time today. I hope that everyone has weathered the rain okay and is doing well. We're very glad that you're able to join us today. Today is our third and final developmental screening webinar. It's a panel discussion on developmental, autism, and perinatal depression screening. I'm Ashley Poley. I'm the Executive Director of the Louisiana AAP, and I will be the Zoom facilitator today, along with our staff, Taryn Daigle, who is also on today. We hope that this webinar and virtual community will be a place that you can learn from our panelists as well as your peers. This webinar series was developed through a collaboration between the Louisiana AAP, the Louisiana Department of Health, and the Healthy Louisiana Plan. Again, if you have not taken the opportunity yet, please put your name and credentials and where you're from in the chat box so we can know who's participating with us today. This webinar has been accredited for 0.75 AMA PRA Category 1 credits for physicians, 1.1 contact hours for nursing education credits, and 0.75 general contact hours for social work. Since we are hosting today's webinar as a webinar and not a meeting, all participants' audio and video have been turned off. Please remember to use the chat feature and the Q&A to ask questions, share ideas, or share resources. If it's something the full group you'd like to share, then be sure in the to drop-down field, you select all panelists and attendees. Today's panelists will be Dr. Laura Thornton, Dr. Amanda Dumas, Whitney Martinez, Cindy Caroon, and Norma Seguin. And again, this will be moderated by the Louisiana AAP staff. I'll stop sharing my screen now and let you ladies take it away.
Hi there, folks. I am Dr. Laura Thornton. I am a developmental psychologist with the Louisiana Department of Health Bureau of Family Health, which sits in the Office of Public Health. So as always, many of us are aware that there has been a lot of rain recently, and technology is not always what we want it to be. So please bear with us if we have some technical difficulties or if anything gets a little disrupted, but we will make sure that this recording is available for you and you will be able to continue to watch things in the future as it will be posted online. So bear with me while I get my screen share started. And in this time, I'd like to invite Dr. Dumas to introduce herself, and then followed by Whitney Martinez and Cindy, please.
Hi, I'm Amanda Dumas. I'm a pediatrician with LSU in New Orleans, and I am also the Associate Medical Director at Medicaid. So I've worked closely with my partners at Medicaid, including Whitney, Cindy, Norma, to help write some of the policy around the new developmental autism and perinatal depression screening reimbursement that I know there are a lot of questions about. And certainly we've worked as well in collaboration with the Bureau of Family Health as they've been updating their own developmental toolkit and how that might align with our policy. So thanks for having us.
Hi, my name is Whitney Martinez. I am the Program Manager of Provider Relations, Provider Networks, and recently added Provider Enrollment. I just want to say I have a background before I came to the state almost 5 years ago on the provider side, and was actually working as an administrator in a pediatric clinic for 20 years. So thanks for having us. Cindy? Cindy and Norma may be having some technical difficulties, Dr. Dumas.
Yeah, that's certainly understandable today. We can certainly have them loop in again later, but we appreciate their input. Okay, Laura.
This is Cindy. Can you hear me?
We can hear you now, Cindy.
I'm sorry. I am having some technical difficulties apparently. Anyway, Cindy Caroon. I'm a registered nurse and have worked at Medicaid for about 18 years in various programs, including as an EPSDT manager. Right now, my responsibilities as a program manager are over professional services, physician type services, and those that include EPSDT. We've enjoyed working with Dr. Dumas as a relatively new Medicaid member, and hope that these policies will be helpful to everyone, and that if there are questions that we can clear them up either today or subsequent to the call if things need further research.
Thank you. And we can just check if Norma has been able to connect. Okay, maybe not yet.
It looks like she may be trying to connect to audio, so we can. It may give her just a few minutes to be able to get there.
Absolutely. We will try and loop her in when she is available. Again, you know, technology is technology, and we are all just trying to get through all of our days safely and not impacted by flooding. So hopefully we are extending lots of grace to ourselves in trying to get through all of these things, and you all are as well. So from here, we will kind of jump into some of the overviews of why screening needs to be happening, some findings of trends in a recent survey that you may have completed as well, and reminders around where you can find implementation training and support, and then really opening up for a lot of questions and discussion, because we know that while a lot of information has already been put out there, you all in clinics are often the ones to be able to figure out how do we make this go, and how do we make this go in our particular clinic. And so you all have spent time thinking and doing all of these things and have really important questions that we will do our best to answer. So bear with me yet again. Things will go from there. Also, currently none of the panelists have anything to disclose in terms of conflicts of interest. So many of you are very familiar with screening and why it should be happening, but we wanted to reiterate and highlight some of the findings or reasons that it may be particularly pertinent in your clinic and in your practice. And a recent study by Barger et al. In 2018, looking at the National Children's Health Survey, found that when physicians were conducting both monitoring and screening, more children were being referred to early intervention and therefore receiving early intervention services compared to either just screening alone, which had a higher rate, or just monitoring alone, or just reviewing developmental milestone checklists. So really seeing that additive power there between both those regular discussions around developmental milestones and monitoring. So using, say, a developmental milestone checklist from Learn the Signs Act Early or the CDC, and then using those validated screening tools like the MCHAT or the Ages and Stages or PEDS-DM, those well-validated tools that are similar to populations that are in Louisiana, and particularly that combination as well. And happy to send people links to all of these studies as well. And the other part is Medicaid EPSDT. So all of those preventative visits, screening is indicated at numerous points throughout that entire process. And while I'll let all of our Medicaid colleagues speak to this more directly, it's something that is outlined by the AAP and specifically within Medicaid's EPSDT guidelines as well. Dr. Dumas or any of our other colleagues from Medicaid that you all would like to speak to that more directly?
Sure, I can reiterate some of that. So the AAP periodicity schedule, developed in conjunction with Bright Futures, as most of you will know and be familiar with, does lay out the recommendations for what screenings need to occur at different ages for the EPSDT preventive visit, or commonly referred to as the well child visit. And Medicaid adopts this same screening template. So anything that's listed as a recommendation on that periodicity schedule is required by Medicaid for the EPSDT visit, with 3 exceptions. One of them is that the AAP periodicity schedule goes through 21, whereas we stop at 21. So ours is, 20 and younger. In addition, we do have more stringent requirements for lead screening, given the high risk of lead exposure and lead toxicity in our state. So where it's only suggested based on a risk assessment in the AAP periodicity schedule, we do require it. And the third piece is really more relevant now and becoming more interesting now that we're reimbursing perinatal screening, depression screening, and that's that we only recommend that at this point. Right now, the numbers are still quite low, and even though it is a recommended screening on that periodicity schedule, it's not yet a required component for Medicaid EPSDT. Perhaps that will change in the future, but at this point, we're only recommending it. So in all other ways, though, our own requirements at Medicaid align with that AAP periodicity schedule. And then to touch on the reimbursement piece, which I'm sure a lot of people still have questions about. So starting January 1st of 2021, Medicaid will now reimburse for the developmental screening, the autism screening, and the perinatal depression screening. And we've outlined the policy that sets the parameters for that. And so we went over that in our last webinar, some of the specifics around what would be accepted. And they include that it must be an age-appropriate, caregiver-completed and validated screening tool as recommended or as described by the AAP standards to meet that. So with that, I think that pretty much sums it up. I'll add one more thing. I think this is actually important to take away, which is that these are screenings that, again, were already required by Medicaid EPSDT. So the reimbursement piece is not for new requirements. It's just to reimburse screenings that should have already been happening. So I do hope that people appreciate that piece and that this becomes something that not only encourages that accurate participation in the program, but actually increases the rates for those who maybe hadn't been doing it yet. And lastly, this is new. It's a new reimbursement policy. And so we expect some kinks and some questions, and your being here today, your participation, your thoughtfulness about this is really going to help us find any mistakes or any edits that might need to be made. So I appreciate all of the thoughts and specific case thinking that may go into this, and we can certainly consider it.
Thank you so much, Dr. Dumas. If there are any other colleagues from Medicaid that want to speak at this moment, or we can just wait and defer to our Q&A portion of the discussion today. But want to give you all a chance if you wanted to speak on this directly.
Hey, Laura, it's Whitney. I don't really have anything to add except being in pediatrics in my past work life for 20 years. Really excited that Medicaid is now going to be reimbursing for some things that probably have already been occurring, and to reimburse it, separately. And so I do think it's a great thing. But other than that, don't have anything else right now.
Awesome. Thank you so much for adding that, because I know for a lot of folks, it's like, well, I'm already doing this, so how does this mean I need to do something different? And for many folks, the answer may be no. So from here, we'd like to review some trends that we found in a survey that went out to folks through a variety of different channels. You may have participated in it, and this was primarily led by the AAP and the Healthy Louisiana plans, really trying to understand what current practices are around general development and autism screening specifically, and what people were looking for in terms of support. And so we'd love to review those with you all now and be able to highlight kind of how this may shift and change what support is available to folks. So want to dive right on into that. 98 people responded to the survey, but many of those people who were responding to the survey were indicating that they were responding for a larger number of individuals than just themselves. So it ended up accounting for around 345 folks and providers. So that's kind of useful information to know. And then everything that we'll be presenting is just the numbers endorsed. So the N, it's not a percentage, but because the numbers in total of who all participated at being at 98, it's very close to what an actual percentage would look like. So we first asked people whether they were performing general developmental screening in the first, second, or third years of life. And about 86 folks said that they were indeed conducting screening. 9 individuals said that they were not, and 3 had no response. It's also important to know that we had folks kind of from all over the spectrum, including subspecialists or others, where it may not necessarily be the traditional part of care for to conduct developmental screens in particular. We also asked about autism screening, specifically at the 18 and 24-month timeframes or in that second year of life. Again, we found people reported similar findings in that 69 individuals indicated that yes, they were conducting autism screening, 19 said they were not, and 10 did not have a response to that one. I want to double check in the chat and make sure if I've got questions as of right now.
Laura, there's one in the chat to the panelists, and if you see that, as part of the child health clinical curriculum, we've partnered with HEAL schools to do wellness screening visits by our students. Is the developmental screening going to be added as a mandated annual screen or just a referral if delays are noted?
That is a great question that I may not have the answer to. I think it would depend upon the guidelines, who is setting the curriculum, and we may be able to follow up with that person offline. Because I'm a big believer in saying, if you don't know, you don't know the answer, and we'll find out what we know about that particular answer. And in this instance, I don't know off the top of my head, but we will follow up directly with that person. Thank you. Any others that have emerged?
Nope, we're all clear.
All right. So we asked providers also, what are the primary barriers that you see to screening in your practice? And what we found was that lack of referral connections was not as big of a concern as we may have initially anticipated, but administrative burden had a few more endorsements, and the endorsements increased when it comes to the difficulty of using particular screening tools with your EHR, because so many EHRs are different. There's a lot of kind of individualized work that often has to go into it. And then the two barriers that were most commonly endorsed was fees or costs of particular tools, and that it was time consuming or resulted in patient care delays, or took up too much time during visits. So really many of these were things that we often know of and have seen as barriers to screening, but were able to at least indicate or be able to show information around particularly screens that are free or very cost friendly, and how to maximize that within, how to maximize developmental screening in your workflows. And that will come a little bit later in some of the implementation stuff that we will point you all to. Any questions that have emerged from that one? These are excellent questions.
Are you able to see those? That's the.
I am. The first question is regarding perinatal depression screening. If this is positive, who will initiate referral to services, OB or PEDS? And then in the OB side of care, do they also have this perinatal depression screen on the mother postpartum visit? Again, excellent questions. And it depends upon the needs and organization within your particular clinic. And typically one of the things that we recommend is that if you are identifying the screening, that you would then make the referral. So PEDS would then make a referral. But if you're also in an organization that has collaborative relationships, and you all, when establishing care with a new family and patient, can say, hey, let's be able to talk about this, and if it is all right for us to share information and have that care team across your OB and any other mental health practitioners as well. So it often depends on the problem solving or the specific policies of your individual organizations, but my understanding is that it is not specifically specified what the chain of command would need to be from that, beyond that, as long as referrals are happening, as the people who are conducting the screens would need to then make that referral. Dr. Dumas, I'm happy to tag you in if you've got.
Sure, yeah, in my experience as a pediatrician who's been doing this, it really depends on that caregiver and what the needs are in the screening. So if you discover that someone is actively suicidal and a danger to themselves or the infant, then you have to respond to that appropriately and get them to an emergency room. And so we've called an ambulance before, and then it does require help with figuring out who's the caregiver for the baby then, and what sort of supports need to be identified. Fortunately, that's been rare in my experience. More common is the mother who's having some moderate depression symptoms. And so you have the conversation about, well, what are your supports? Do you have that relationship with your obstetrician you can call? Okay, let's go ahead and call them, or I'm going to check back with you, make sure you've called them to set up an appointment, or do you already have a mental health resource, or can I help connect you to one that you need? So I think a lot of it is like anything else we do when we find out there's a need for the family or caregiver. We have a conversation about where we might be able to fit into that facilitation of services. And in terms of what's appropriate to do then, it's document like everything else. Document your concerns, document what you were able to do, and if follow-up is needed. I know that there's some clinic flow issues with that, with different practices, but as Laura was saying, it really depends on where you're working and what sorts of resources you have as to how you're going to incorporate that.
Awesome, thanks so much, Dr. Dumas. From here, We also asked people about what desired supports people are wanting in terms of how to implement developmental screening. And our kind of lowest endorsement was for participating in a learning collaborative. So working with other hospitals or clinics together to implement something. But in increasing endorsements included the free provider education, like you're attending right now. But the two greatest endorsed supports were having implementation support for how to make this happen in your practice, and having administrative and organizational support for the implementation of the practice. And while all of us can certainly work to provide that implementation support piece, it is also helping make that case for admin and organizational support. And the nice benefit now is that there is additional reimbursement, and so that makes a better business case of being able to do that. And so those were kind of key takeaways there in terms of what the barriers are, what desired supports people are indicating. If you have different desired supports, or if this isn't meshing well with your individual experience and you have identified a key need, feel free to put it in the chat, or feel free to send us an email at devscreen@la.gov, and we'll show that email a little bit later. So from the trends, we'd like to just give a reminder about the implementation, training, and support opportunities that are available to practices across the state. And you can find out a lot more information about this in our first webinar, and we also touch on it in our second webinar, but we will drop some links in the chat, specifically with the Louisiana Bureau of Family Health's Developmental Screening Online Toolkit. This is here really to provide a DIY to very one-on-one kind of experience of being able to provide you all with some of the tools to help make implementation a little bit easier. And if you are very familiar with implementation or improvement science, or know how to make things go in your particular clinic and are very comfortable with that, then a lot of this is going to be like, great, this may be helpful, and you're kind of off on your merry way. Whereas other folks may need a little bit more time or have questions around, how do I make decisions around which tool to use? Where can I train all of my people in the clinic who are going to be administering these, how to do the screens? How do we figure out how to make this work into our clinic workflow? We also have implementation training and support through either one-on-one coaching or small group calls, where we can provide that as well. So highly recommend checking out the particular toolkit, and we have it separated into where to find that training and support. Often it's just shooting us an email to attending different webinars like these, or office hours, or going through the kind of three-step process of assessing and creating your plan for what you want to do, making sure that your team is trained, and helping you implement that plan. And last but not least, because we know that the other part of screening is making referrals, we have a great list and connections with excellent resources to kind of the most common places that we often need to make referrals. And last but not least, as a kind of final plug, is that it is MOC4 eligible. So you can get those additional credits, and we will happily walk through this process with you all. And we use the kind of plan, do, study, act cycles of testing things out, seeing if it works, what do we need to tweak so that it continuously gets better and you can make kind of quick decisions through testing and have evidence of this is why this is working. This one particular change didn't work, so we're going to try something else. So happy to walk people through all of that, and you can find it on the LDH website at ldh.la.gov/dev-screen-toolkit, and we'll also throw some links in the chat as well. So in reviewing all of this, we really wanted to get to kind of the meat and potatoes of today after reviewing some of these things to really allow people the opportunity to ask questions, several of which have already come in, and we want to make sure that we've got plenty of time for that so that we can continue this conversation. So I will just quickly plug that we will have a link to the evaluation that you need to complete for continuing education. I did see a question earlier about counselors and CEUs. We did not necessarily go through the counseling board. However, sometimes there's also reciprocity if you are able to show that it has met criteria for physicians, nurses, or social workers. And last but not least, to plug to send us questions at the devscreen@la.gov email. This is the best way to get in touch with the Bureau of Family Health in terms of questions around developmental screening. And as you saw earlier, if I don't know the answer, I will try and point us in the right direction to help find those answers. So from that, I would like to kind of open it up to everyone, and I can stop sharing my screen if that's what you would prefer, Ashley, and open that up kind of for questioning for everyone.
There were a couple questions following up on the perinatal depression screening.
Awesome.
We discussed the issue of, what to do if you have a positive screen, and that's a little bit variable depending on the mother's or other caregivers' symptoms, how bad it is, and your own resources. But another question came in regarding on the OB side, do they also do a screening? My understanding is that OBs are supposed to be screening for postpartum depression, but keep in mind that it's the pediatrician that tends to be seeing the caregiver more frequently because of the frequent checkups on the infant, which is why this policy is about screening the infant's caregiver. So that's very different from the OB screening their own patient. What we're talking about is the child's provider screening the child's caregiver for depression symptoms. And another thing to keep in mind there is that although you may be able to offer some screening and know about their mental health leading up to the birth and maybe very early after delivery, postpartum depression, perinatal depression, these symptoms can develop many months after the birth of the child, which is why it's recommended that the caregiver be screened at 1, 2, 4, and 6 months of that infant's age. So again, just making that differentiation there. This is a code that's being reimbursed for the screening of the infant's caregiver under the infant's EPSDT visit.
So there were two other questions that have come in the chat, and the first one was, can the perinatal depression screening be started at the hospital before the baby's discharge for better coordination of services?
Right, and going back to that, that would really be the providers who are in the hospital. So if it's the OB, that's certainly relevant. The pediatrician who's seeing the baby may also review that with the parent, but that's different from these current guidelines that are really meant to focus on the care in the outpatient setting when you've brought that baby back into the office for their care, making sure the developmental and perinatal depression screenings are occurring at those times as well.
Great. And the other question that we have in the chat now, are we able to go back and refile for an MCHAT screening that we did earlier this year, but didn't initially code for when the first time we sent in that claim?
It's actually probably a good question for Cindy or maybe Whitney. I don't know if that's something you could answer.
Hey, this is Whitney. Basically, check with, depends on, not depends on, but also check with your managed care organization you're with not having all of the details. Amanda, this started 1/1, is that correct?
That's correct.
Yes, January 1st. So if you have already the documentation and you have not billed, typically you have 365 days to bill within Medicaid. But if you're with your managed care organization, I would definitely contact them on any specifics they have in regards to billing. Cindy, I don't know if you have anything else to add for that.
Thank you, Whitney. And I will share at the chapter level, we are working to try to put together some kind of document for folks with information from each of the NCOs on how they are processing those kinds of situations and what their policy looks like. From my understanding, some plans were automatically going back and kind of filing and seeing if that was in there. Some plans were wanting you to file it again. So we're trying to kind of tease out what each plan's specific processes looks like so we can share that with everybody. So hopefully we'll be able to get that together.
Actually, and
there were,
that brings up a good point real quick. If you had already filed it, yes, the NCOs did a recycle all the way back to 1/1, and all of those claims should have been paid. If you have never refiled it, obviously they couldn't pick it up, or never filed it, it would have been picked up in the recycle. So if you have the documentation to support it, you've never filed it, you should have 365 days to do it and could file that right now. Thanks, Ashley.
Sure, thanks, Whitney. So next question from the Q&A, is there a specific form to use for the perinatal depression screening? If so, can we provide a link for that?
Hi, so the screens that are accepted for Medicaid reimbursement include the Edinburgh postpartum depression screening tool, the PHQ-2, and the PHQ-9. Noting, of course, if the PHQ-2 is positive, you do need to do the full PHQ-9. So you don't have to have the form shared. I think the next question is, do you need to have that form shared? You don't. You just need to document what screen you used, what was the result, and what you did as needed. So that is in line with AAP supported tools. And in terms of links, they're all free. So you can actually Google it. You can find the EPSDT, I'm sorry, not the EPSDT, the Edinburgh postnatal depression screening form online. Some places are incorporating it into their EHRs. For example, you can have that in Epic so that you can do it in your EHR, or you can do it on paper and then just record the screen in your charting. There are a lot of ways to operationalize this. And again, it kind of depends on your own clinic flow and resources.
Thank you, Dr. Dumas. I think that probably answers the second question there about required documentation. Dr. Queen, if you've got a follow-up question to that, if that didn't fully answer your question, certainly please add that to the Q&A. As of right now, the Q&A and chat is clear. So I will just make a last call. If anyone has additional questions, go ahead and put those in there. In the meantime, I'm going to put a couple of links into the chat box and share my screen again so that you can see that. Just a moment if I can get these to work. One, as we were discussing technical challenges. Okay, so on your screen, you should see a couple of different things that you will receive following today's presentation. We will be sending a link to the evaluation. We will be sending a link to today's recording of the video, the slides from today, and the other links that have been mentioned in the in our webinar today. We'll also be including the email address devscreen@la.gov, which is the best place to reach these ladies with any of those specific questions you may have. And then you'll also get information about our mental health symposium. We're hosting that August 19th in Shreveport. It'll be a full day of mental health education. And so you'll have information in the follow-up email there. So let me, looks like we've had a couple of questions that were going into the chat box and Q&A. Folks are answering those. Let me one more time see if I can share. Apologize, I'm working on multiple screens here. In the chat box, I am going to put, there we go, a link to the evaluation, the email address, and a link to the flyer. So if you want to go ahead and click on those now, it'll open those tabs up for you so that you can access them after today's presentation. So we've got a few more minutes. I'll leave this open so you can see those links, as well as if you want to add any more questions in the Q&A or chat box.
To answer Dr. Queen's question around free or very affordable screening tools on general development, we highly recommend either the AAP's website called screeningtime.org, and their STAR Center also provides implementation training and support, which you can reach out to directly, or also our developmental screening toolkit. Our primary one that we recommend is the Ages and Stages. Although it is not free, it is around $300 for a starter kit. And given that the reimbursement is $10 for each screen, if you're screening more than 30 kids in a year, you're at least making your money back on that one. But happy to point people in various directions. And the Screening Time website is really excellent, and you can filter through for a variety of things there. Feel free to add, Dr. Dumas.
I would just note that all the perinatal depression screening tools are free.
Excellent. So there was one other question added to the Q&A. Are there any frequency limitations on the 96110?
Yes, so that's the code for the developmental screening and autism screening reimbursement. And again, we follow the AAP periodicity schedule for that. So those recommendations are for the autism screening at 18 and 24 months and developmental screening at 9, 18 and 30 months, I believe. So that's up to 5 screenings that we would expect normally developing kids to be, receiving and see that code for. However, the policy does allow that if you have a documented reason for needing to screen that child outside of those times, that's acceptable. So for example, you have a child with another medical diagnosis that makes them at higher risk for developmental delay, or the parent is coming to you with a concern, or on regular developmental surveillance, you note a concern, and that triggers a formal developmental screening tool being used. That could also be an acceptable reason to use that code.
Well, with that, I will say thank you all so much for joining us today, and I hope you all stay safe with the remaining weather that we're expecting over the next few days, and have a great rest of the week. Bye, everyone.
Thank you.